for the management, the most common regimen which is being followed is mid-path regimen. All you have to remember in this mid-path regimen is that first of all, you have to divide the patient into two categories. As far as management is concerned, divide the patient into two categories. The category number 1, where there could be involvement of type 1, 2 or 3 paraplegia. Imagine a patient is having Pott's spine with either type 1, type 2 or type 3 neurological involvement. That is one category. And the second category is type 4th involvement. You know, the involvement where there was bowel bladder incontinence, where there was paraplegia inflection, where there was more than 50% of sensory loss. So that is type 4th. Now in type 1, 2 and 3, what you have to do first is that put the patient on ATT, anti-tubercular regimen, put the patient on absolute bed rest for some certain duration of time and observe. Then you have to observe the patient. All right. Observation of any neurological deficit. But in case if the patient is having a type 4 affection, if there is a type 4 involvement, then you can go for surgical decompression. Early surgical decompression you can plan along with ATT and rest. Now this observation is to be followed for the period of 3 to 6 weeks. All right. Imagine if the patient is coming to you with the grade 2 paraplegia of tuberculosis of spine. You have certainly made the diagnosis. The patient is having a paraplegia and now you have to go for the management. You will ask the patient after starting the anti-tubercular regimen for complete bed rest. And then you go for the observation. That means you go elicit the symptoms, you elicit the signs again and again, and you look for the neurological benefits. Now, if there are two possibilities, if there is a neurological improvement, imagine if the patient is having a neurological improvement. Now, in that case, you have to go for ATT and rest only. Means you have to put the patient on ATT and you can manage the patient conservatively. But the another possibility is that there is a worsening of the neurological features or there is a no change in the neurological features. Imagine if the patient is not having any change in the neurological findings. Whatever the grade of power loss was there, it is persistent. Whatever the movement loss was there, it is persistent. Whatever the sensory loss was there, it was persistent. The patient is not having any improvement in the sensory, in the neurological functions. Now, in those cases, you have to go for surgical decompression. But you know, majority of the cases in tuberculosis of spine could be, frankly, managed by patient, putting the patient on conservative management itself. All right. So, anterolateral surgical decompression with or without fixation might be required as far as the management of tuberculosis of spine is concerned. So, that is the mid-path regimen that which you have to follow. You know, as far as your questions are concerned, majority of the time they will give you a condition where there is no surgical decompression required. All right. When we will talk about the options, we will talk about some simple question, then we will have a discussion on how the questions are going to be portrayed for that particular question of yours. Hopefully, everything is clear related to the management protocol also. And as I told you, the neurological involvement is actually dictating you the treatment protocols also. So, if the patient is categorized in the type 1, 2 and 3, go for conservative management and observe the patient. If the neurology is improving, continue the conservative management. But if there is a deterioration in the neurological functions, then go for surgical decompression, which was considered to be a primary management if the patient is coming to you with the type 4 involvement. All right. Now, what are the poor prognostic indicators for tuberculosis of the spine? Now, it is not very difficult to identify. Means based on the common sense itself, you can answer these particular questions, that in which case there will be a poor prognostic outcome, in which case there will be a relatively better prognostic outcome. Now, neurological involvement. Imagine if the patient is having grade 4 involvement, it will be a poorer involvement. Lumbar involvement. You know, if there is a lumbar involvement, there is a possibility of a cauda equina compression, and the cauda equina syndrome is likely to be missed because the patient doesn't go for the management initially. So, there could be a delay in the cauda equina syndrome, as a result of which lumbar vertebrae involvement or the lumbar involvement of the nerves would be having a poor prognostic outcome in comparison. Then poor socioeconomic status, yes, because of the decreased compliance, because of the conditions the patient is presenting with, or because of the lack of nutrition. All these three things are responsible for increasing the possibility of worsening of this condition, that is tuberculosis of spine. Late diagnosis. You know, for any condition, if there is a late diagnosis, it will be having a poor prognostic factor. Associated morbidity which is related to immunodeficiency, it will be having a poor prognostic indicator. Angular kyphosis, greater the angular kyphosis, lesser the possibility of getting it corrected. So angular kyphosis is also considered to be a poor prognostic, or you can say greater the angle of the kyphosis or greater the deformity, kyphotic deformity, poorer the prognosis. And finally, if the patient is presenting with the paraplegia, or if the patient is presenting with the neurological deficit where the primary tuberculosis is already healed, that means there is no option of correcting this neurological deficit. There is no hope of correcting this neurological deficit because the tuberculosis is already healed. So in case the patient is presenting with the neurological deficit with the healed tuberculosis, it will be having poorer prognosis. Imagine if the patient is coming to you with the paraplegia or neurological involvement with active tuberculosis. So there is always a hope that if you treat this tuberculosis, then over a period of time, there could be improvement in the neurological functions also. So these are considered to be the poor prognostic factor for spine involvement. So hopefully everything is clear. Just let's have a quick revision of what we have talked about, because every time you get a question related to this tuberculosis of the spine, then most of the time the examiner wants is identification, that you should be able to identify first of all the condition. Second is that you should be able to at least primarily manage the condition. All right. So based on that, he has asked you multiple of the time, this question is now in trend, that most common type of involvement in case of tuberculosis of spine is the paradiscal type. We have already talked about. Next is the treatment of a pot spine where the D8, that means thoracic 8 and 9 are involved without any neurological deficit. So answer for that question is conservative management. Now, will you go for anterolateral surgical decompression? You already know that if there is no neurological deficit, even if there is a neurological deficit which has not progressed to type 4 involvement, you have to go for conservative management. Corticotomy, obviously not. ATT, rest and observation is considered the management. Debridement and grafting, obviously not for that particular. So initially you have to put the patient on anti-tubercular treatment along with rest and observe the patient for any neurological compromise. Next, 23-year-old female came to OPD with a complaint of back pain for the last 5 months. So there will be a long history, vague history of back pain. There is a history of progressive pain which is more at night. Tuberculosis related conditions or tuberculosis related symptoms early in the course of disease are more at rest. Because when the patient goes for rest, there will be a loss of spasm. There will be a lack of paraspinal muscle spasm. As a result of which, the two affected joints or the two affected bones will be frictioned against each other. And because of this frictional movement, the patient will be experiencing more pain. All right. So there will be more pain at night with persistent fever and weight loss. On examination, there was a tenderness. Localized tenderness will always be there in case of direct involvement of the vertebral column. SLR was found to be 80 degree, but more importantly, there were brisk reflexes in the knee and the ankle with extensor plantar reflex. Now, X-ray shows reduced disc space in between T10 and T11. What is the most probable diagnosis the patient is suffering from? So when you combine all these features, you will only get one differential diagnostic hint in your mind, and that is tuberculosis of the spine. So what all we have discussed in the tuberculosis of the spine, what all you should know about the tuberculosis of the spine are the involvements. Most common site we have talked about, it is always it is always secondary. Most common route of spread is hematogenous. Paradiscal is the most common type. Appendiceal is the least common type. And in the appendiceal, it is the facet involvement which is the least common site to be affected. The clinical features are vague, they are non-specific, which will happen in all the other conditions, but what you have to think about or what you have to locate in the clinical feature are the presence of the constitutional symptoms. All right, are the presence of the constitutional features like fever, anorexia, loss of weight, loss of appetite, all these things. Next, neurological deficit is something which you have to importantly remember because it will dictate the management of the tuberculosis of the spine. As far as X-rays, we have already discussed about what are the important X-rays which the examiner will always put for you to identify, and that will be reduction in the disc space. The poor prognostic factors are all based on common sense. All right, this list could be including many other factors also, but all of them are based on the common sense involvement. Next very interesting topic is the tuberculosis of the hip joint. Multiple subtopics we are going to talk about in this particular very commonly observed and likely to be kept in your examination. a kind of a topic where there will be a differential diagnosis discussed in relation to this particular heading, that is tuberculosis of the hip joint. Now, under the heading point number 1, which is being written over here, is the acetabulum. It is actually, why acetabulum? Because it is the first most common site to be affected by TB hip. Now, some of you might be questioning that what does it mean? Like, you know, hip joint in itself is a single joint. Now, what is the most common first site in that joint to be affected? You know, hip joint is made up of acetabulum, head of the femur, and the synovium in between. So, any of the site could be affected first. But the most common first site always to be affected is the acetabulum. So, in front of acetabulum, it is the most common first site to be affected. Alright. Next, night cries. Now, the patient is usually observing or having more pain, particularly at the time of rest in the initial events of the tuberculosis. Now, this is something which we are going to discuss over a period of time later. But at this point of time, you just remember that the patient is experiencing more pain at night. Then, there is always a long history of around 4 to 6 months, but not that long or up to an extent of involvement, for example, for about 1 year. So, it is less than 1 year, but certainly more than some weeks. So, it will be a history which is provided to you always in between around 4 to 6 months of history. Now, pain will be a preceding event. Patient will be experiencing first the pain and then there will be a limping. The discomfort in walk will be a secondary symptom or a second sign, but always there has to be a pain first. As far as constitutional features are present, like there will be a loss of appetite in any infective or inflammatory pathology. Like there will be a loss of appetite, there will be weight loss, there will be persistent fever. So, all these features will be present in a patient who is suffering from tuberculosis of the hip joint. And finally, the most important part of this particular topic, that are stages of tuberculosis of the spine. Now, before we talk anything related to the stages, let's have a discussion on the stage itself. That, you know, this progression of the disease is in stages. Like first there will be synovitis. So what does synovitis mean? The first stage of inflammation. The first stage, what will happen? There will be a collection of the abscess, or there will be a transudate, there will be a collection of the fluid inside the hip joint. Now, hip joint is a closed space, so it will lead to several key clinical features. Similarly, with the progression of the disease, it will lead to arthritis. That means there will be a destruction of the joint surfaces. Then this arthritis will also become advanced arthritis, and finally, it will culminate into a situation which will lead to a dislocation of the hip joint. Now, let's have a discussion on the stage 1, that is the stage of synovitis of the hip joint. Now, all of you know that hip joint is a closed space. We are going to talk about the stage 1 of the tuberculosis of the hip, that is the stage of synovitis. Now, all of you know that hip joint is a closed space. It is encapsulated space. So, for example, the carrying capacity or the volume of the hip joint, for example, is 5 milliliters. All right. But if there is a collection of the fluid because of this inflammation of around additional 5 ml, that means now the hip joint has to accumulate 10 ml of fluid. Now, this increase in the volume of the hip joint, the condition will be rendered painful. And how to limit this pain involuntary? You know, the patient is not voluntarily decreasing or attaining the attitude in which the pain will be reduced. It will be an involuntary mechanism. So, how involuntarily the patient limb will be kept in a position which will result in the decreased pain? That is, the only thing is by increasing the volume of the hip joint. So, if you increase the volume of the hip joint, there will be a reduction of the pain because that excess fluid will be equilibrated. So, how to increase the volume of the hip joint then? In order to increase the volume of the hip joint, the hip has to move into flexion, because the flexion increases the carrying capacity of the hip joint. It increases the space in the hip joint. Second, it has to move into abduction, and it has to move into external rotation, because when the hip joint moves into flexion, abduction and external rotation, there will be increase in the volume of the hip joint. There will be increase in the space of the hip joint. So, the patient can accumulate excess amount of the fluid without having too much of pain. Now, if this is the attitude, if this is the position in which the patient will be experiencing less amount of pain, so the patient will acquire this attitude, and that is why